Uh, Thanks so much, Krisha. Is my audio okay for people?
Yes, it is.
Okay, it's really a great pleasure to be with you today to share with you a very brief introduction over the next 3 hours to the use of dynamic models for exploring to address the challenges associated with the prevention, control, and management of infectious diseases. And I'd like to begin by thanking Krisha for this invitation. I've been working in the area of application of computational informatics tools to specifically to health now for over 2 decades. This work has involved a lot of focus on communicable and infectious diseases, although has also reached many other areas, chronic and environmental epi, for example, health services type of issues. But much of our work also works at the interface with cognate areas these days, such as social services, the provision of corrections and policing services, and other components that are cognate to health. My name, as you heard, is Nathaniel Osgood. I serve as a professor in the Department of Computer Science, associate faculty here at the U of S in Community Health and Epi. I further serve as the lead research advisor for the Saskatchewan Centre for Patient-Oriented Research, and as director of the U of S's Computational Epidemiology and Public Health Informatics Lab, which we founded a number of years back to work with worldwide partners, including many governments and decision-making organizations, to address health priorities using tools from computational mathematical modeling, as well as other types of related informatics. So within these 3 hours, I'm going to be providing a whirlwind glimpse of the ways in which we can use dynamic modeling to explore some of the challenges of infectious disease. In order to do that suitably, I'm going to, I'll give a first glimpse of the practical manipulation of some tools here. It's important that I provide a sort of conceptual and indeed even a philosophical foundation for understanding these models. These models are, on the face of it, unfamiliar probably to most of you. They will also be probably in quite some contrast with many other forms of modeling that you've explored within your time in public health and epidemiology, etc. And I'd like to provide a bit of a conceptual foundation for understanding the ways in which these models function, what they are, what they're not, and especially to provide a perspective on them which is not widely appreciated, but I think provides a much more grounded understanding of their potential than common misperceptions would offer. And we'll be spending the bulk of today's time together within that task. Finally, as time allows, we may be able to explore a little bit of building up a model like this ourselves. Whilst we'll be doing some practical hands-on exploration at first, I do hope to come back around to it to give you a bit of a glimpse about how these models are built up. However, to do so will require a bit of time, and we'll see if the time affords it. Okay? So I'm going to begin here by sharing my screen. And we tried it earlier, and hopefully everything cooperates here. Can people see my screen okay?
Not quite yet.
Is it-
Looking like we
might need to get you to turn off your camera. Oh, there, your video just came back.
Okay.
Getting some bandwidth warnings.
I see. Okay. So maybe I will turn off my video then. So you're still not seeing my screen, is that correct?
Actually, it just popped in.
Okay. So you can now see, for example, a presentation?
Yes.
Okay, great.
Yeah.
I'd ask people, so I appreciate the feedback on this. It's very helpful and timely. I hope that people will speak up without any concern if you lose my screen sharing at some point, or if there's something that I'm clearly doing which is just not showing up on the screen. That may be a sign that the video feed from the screen has been interrupted. So please speak up if that's the case, and we'll try to remediate. Okay. Okay. So I had asked Krisha to kindly offered to circulate to the students in this class two things. Number one, directions on where you could download a program that I indicated that we'd be using in today's session, a program called VenSim PLE, Personal Learning Edition. This is a free and popular tool for exploring some of the basics with an important subclass of dynamic models, and those are compartmental models or system dynamics models. These are aggregate models we'll be focusing much of our attention on today. And secondly, beyond providing those instructions about how to download that, Krisha had offered to circulate a model that I would provide. And I did go ahead and provide that last night with a slight update this morning. Did Krisha, did you get a chance to send that out then?
Yeah, it's all there. It's all
Great.
On Blackboard. And the program, the link to the VenSim PLE that was sent to the students ahead of time, so they should have it downloaded on their computer.
Great. Okay, so I will trust that the students have downloaded, installed VenSim PLE, have obtained the model that Krisha kindly posted within Blackboard, and that you can go ahead and open that model. If students had any trouble undertaking those tasks, if they have challenges running the program, there's not time to individually take on those challenges here, but you can rest assured that we will be moving on to lecture slides within about 20 minutes. And if you just follow along some of the things I'm pursuing myself on the screen, you should get a lot of the flavor of what you'd see on your own screen. So I've gone and loaded in this model here. My screen, because I'm using a slightly different version of VenSim, my screen may look a little bit different than yours in some of the particulars. But if you load in the model, you should see something like what stands in front of you right now. It will seem a buzzing, blooming confusion. And it's a buzzing, blooming confusion will help you parse out in the course of today's lecture. Broadly, though, what you'll see is a set of modeling constructs, a set of modeling components, variously called stocks or levels or state variables, shown here as rectangles. Those indicate different subpopulations of a broader population. So we have people in this model divided into susceptibles, exposed, infective, asymptomatic individuals, infective, yet undiagnosed symptomatics, but also symptomatics who are diagnosed. We also have a hospitalized stock representing people currently requiring acute care, and a stock of recovered individuals, either undiagnosed or diagnosed, and some numbers of people who have passed away from coronavirus. So these these compartments or stocks, which we'll be introducing later in the lecture as a building block of these sorts of models, these aggregate models, characterize at any one time how many people are in each of the states. So how many people at any one time are susceptible, exposed, asymptomatic, but infective, and hospitalized, etc. At any one time, we can summarize, as we say, the state of the model, the current situation, by specifying how many people are in each of these states. In addition to that, within this this diagram in front of you, you'll see these things that almost look like flows, or they look like pipes or something with a big arrow with these two parallel lines. These are what are called flows, and they indicate a transition between one stock, one of these accumulations, and another. So in this case, we have an infection transition here. So it's at this point in the model that individuals become infected with COVID and with the COVID virus, and that brings an infected individual who has been thus far susceptible into the exposed state. After some period of time, that individual will flow over into the state in which they're infective but pre-symptomatic. They don't yet have, are not yet showing symptoms. And in the fullness of time, they will develop symptoms, and some of them may seek care. So this, in short, is a model that depicts a certain theory of how COVID, the burden of COVID is felt within a population. The COVID virus shapes much of this model, but elements of the healthcare system shape other elements. For example, we have individuals who seek care, and a certain fraction of them, for example, are admitted to the hospital. And there's some elements associated with case finding, active case finding in the form of individuals, for example, who are found via mass testing, as might be seen with targeted or broader testing regimes. Now, this is a theory of COVID that is drawn out here in quite specific ways according to a diagram language called stock and flow modeling, or Forrester diagrams. And it's a very popular type of way of depicting our understanding of the structure of a dynamic system, of a system whose change over time depends on its current situation. For example, if we have no infectives in the population whatsoever, even if we have a population full of susceptibles, no one will get infected. By contrast, if we have some infectives, that allows people to become susceptible. This is a system whose change over time depends on its current state. How many people become infected for each day depends on how many people are already infected, for example, as well as how many people remain susceptible. So we call this a dynamic system. And it's quite different as such from many systems you might have explored, for example, in a biostatistics class, or in the context of exploring simple stochastic systems. Now, within the context of a model like this, though, it's more than a diagram. A model like this helps us kind of structure our thinking of the stages of the natural history of infection that people can go through. It helps us structure our thinking about how one stage might lead to the next, about at what point, for example, people seek care, at what point people might be found via testing within the population. But it does more than that. What you see in front of you in the form of this model is not only a visual depiction that can communicate our assumptions and invite helpful critique, it's further a precise enough specification that it allows us to ask what the consequences, what the natural logical implications are of a theory of this sort in terms of the behavior it will exhibit over time. This is a dynamic system, I said. Its state determines what changes are possible. And with a model that's articulated in a fully specific way, a dynamic model where we have associated with each of these boxes some initial value, each of these flows some formula, we can actually say, what if this is a reasonable depiction of the situation, what would be the logical consequences of that over time? And this is why we call it a dynamic model, because it's characterizing, given a certain understanding, a certain posited structure of a system, a certain theory captured in this model about how things work, what the natural history of infection is, we can ask, what's the consequence of that over time? What sort of behavior will that lead to over time? So those of you who have this model open yourselves, I'll ask that you join me in a bit of exploration of that behavior. So I'd like you to go up, and you should see somewhere on your screen, and again, it will differ a little bit by the Vensim version you're using. You'll see a box that asks for a file name. And if you type in baseline there, and you press enter, it may ask if it already exists, if you want to overwrite it, as it did there, but or it may just run it out. Now, running it out means taking this theory that's depicted here and explicating its logical implications, telling what does this theory mean for behavior over time. If this is the way things are in the world, if that's what we posit, what would it mean in terms of what we should expect to see in the world? So we just ran that model. Let's go explore what behavior was induced, what behavior was generated from this model. And I'm going to make sure that I'm viewing the same basic scenario as you. If you scroll down, you should see something that says major stocks. That should be on the lower part of this model. And what this is depicting is behavior over time. On the x-axis is time. That's time in days. The y-axis is values of different variables. Remember I said that each of these compartments counted the number of individuals at a given time who are in the corresponding state. For example, the number of individuals who remain susceptible, or the number of individuals right now who are in the hospital for COVID-19. Those counts are indicated in this, for any one time, are indicated within this graph to the lower left. So let's consider a given point in time here. Let's consider, for example, time 146. What's time 146 in my graph? So at this point, what this is saying is there's a certain number of susceptibles. That's the blue here. For example, there's a certain number of these would be hospitalized individuals. That's the black. There's a certain number of individuals who have been cumulatively affected by COVID. The attack rate thus far is such and such. And we have another output yet for the number who have been killed via coronavirus. By the end time, for example, within this particular model, somewhere over 4,000 people have died from coronavirus by the first year. We have a number who remain susceptible, which is under half of what it was originally. And we have a number of individuals who are in the hospital, which is very low. It was larger earlier, but it's become very low by then. So this is giving some outputs that give a sense as to that behavior over time. You can also go and if you are in a mode here that's shown in mine by this lock here, we can actually go double click on a stock and go view an output from it. How did I do that? I made sure I was in the right mode. I double clicked on the stock. That meant it knows that I care about that stock. And I went and I clicked this graph thing on the left. So here we see a graph, for example, of the number of susceptibles over time. It starts somewhere upwards of 1 million for our province and declines precipitously during this certain time, but sort of plateaus out and remains almost unchanged for the last half of a year or a third of a year or so. We can go look at other quantities we might be interested. For example, this quantity up here, effective prevalence of infectives in the mixing community. And we can go graph that. And for example, we see that the prevalence of infection in the community, that's not to say diagnosed cases, prevalence of underlying infection here reached above 10% sometime just before time 146. After rising steeply, and then it declined. And we could go explore other quantities of interest, perhaps, for example, the hospitalized. So a model like this, which reaches a peak bang on at time 146 or so. So a model like this is taking an operationalized theory, a theory as articulated a model like this. A model articulates a certain theory and captures it in an operational way. And it says, okay, what follows from that? What's the implication from that? Go figure. What does that imply about behavior over time? And we've just seen that for a baseline case. And that provides a lot of interest. For example, we might be at a certain point in this continuum right now in terms of hospitalization. Maybe we're at time 73, and we want to know, is it going to go up or down? And what this suggests is it's going to go up and up and up and up. That might be useful for anticipating what's coming, for undertaking surge planning, etc. But there's many other uses of these models that go beyond an attempt at projection or forecasting, which is always a bit dicey with people undergoing behavior change, with interventions put into place by parties that we can't control, by terms of events, in terms of knowledge, attitudes, and beliefs about a pathogen such as coronavirus. In addition to serving as kind of to help us anticipate, we can also ask what-if questions. For example, we could ask a question, what if we were to engage in a process of restricting the number of people who arrive into the model each day, say from overseas, the number of arriving individuals who are symptomatic. So I'm going to double click on this arriving undiagnosed symptomatics, and you'll see that about per day, we've about a third of a person arriving here per day who's infective. And we might be concerned about that. I'm going to go into what's called synthesim mode. The button may show a running person on your computer, or it may show other types of icons. I'm going to enter into that, and that will allow me to actually interactively change assumptions. So I'm going to say reducing arriving infectives. Okay? I'm going to give it a new name of a scenario. I'm going to press enter so that it will run it, but I haven't changed anything, and it's going to show the same results there. But I'm going to reduce the number of individuals arriving per day from, say, 1,000 to 100, maybe by closing the border, for example. And what we see now is a result that's different. The original scenario, the so-called baseline, where we made no changes, was in blue. This alternative scenario, where we reduced arriving infectives, is in red. We see that these graphs are over time, and if we look, for example, at the number who are symptomatic, we see almost a a mirror image of the earlier curve later. So can anyone tell me what has been sort of the net effect of reducing the arriving infectives? That's the red line compared to the baseline where we had 1,000 arriving per day. The red line, we have 100 arriving per day. What's been the net effect of that? Can anyone tell me? Has it reduced the infection over time?
No, it's just delayed the onset.
Exactly. It's delayed it. It did buy us time, but it didn't eliminate the danger. And some number of weeks later, we will see basically the same scenario play out that would have originally played out. We've bought ourselves time perhaps to prepare, and hopefully we've used that wisely. But it hasn't dealt with the core issue. So we're going to try modifying a few other types of changes to see maybe other types of interventions would help. Okay? So one thing we might try, for example, beyond this, would be, we'll say, mass testing of 5,000 per day. Okay? And I'm typing that up there. I'm going to press enter to run it. But first, we've got to make it interesting output, we want to go reset this back to its original value. After all, this one is something, that we don't want to change anymore. So I just changed it back to 1,000. That's its original value. And now what I want to do is I want to go down to, there should be a thing called individuals mass tested per day. We're going to change this to 5,000. Okay? Now we see something different. We still have the red. That was the scenario we ran with reducing the number of people coming in. We still see the blue. That's the baseline where we've done nothing extra. People just presenting for care. But now we have a green scenario. And if I double click on this graph, you'll see actually there's a green scenario. So tell me, is this also a scenario which just delayed the peak, or did it do something more? If we compare the green with the baseline, the blue, how did the green modify things when it came to the number of symptomatics here? Well, it delayed it slightly. The peak is a little bit later, but the peak is also a bit lower. It's brought it down a bit. Interestingly, by delaying it a bit, we still see a larger number of cases. We see a larger number of cases extending a bit later than the blue. The green is over the blue here. But it seems like the cumulative number of people infected probably is less. And we don't have to leave that to guesswork. For example, we can go down here and we could go look at the cumulative number of infections. And here we see that, yes, indeed. So how did I do that? I scrolled down, I double-clicked on cumulative number of infections, and I clicked, and here we see the green asymptotes to a level, reaches a level below the blue. That means cumulatively, if you total up all the infections which have occurred over time within the first year, the first 365 days, remember it's time on the x-axis, we've reduced the number of infections by some number. We can go look at other things too. For example, the number who are in hospital at any one time is of great interest to our care system, so we don't overwhelm the beds. Or, God forbid, the number who die. You'll notice that it's not necessarily a proportional reduction. The number who pass away is actually reduced somewhat more than we've reduced the number infected. So we've actually made more of a dent here in terms of the number dying from infection. So we've examined two types of scenarios that are based on interventions. I'd like to walk you through two additional ones before we switch to the slides. Okay, now in order to do this, I'm going to go and I'm going to say, so 20% reduction in mixing, okay? That's going to be how we operationalize contact, limitations of contact patterns associated with social distancing. I am going to have compare apples with apples, compare this with the baseline and with the other scenarios in and of themselves. I'm going to go down to this, how many mass individuals are mass tested per day, and change it back to 0, its original value. Okay.
Sorry.
Yes.
May I ask a question, Dr. Osgood?
Sure.
Sorry to interrupt.
Sure.
Can you hear me?
Mm-hmm.
With the mass testing, I don't know if I understood you, and I don't know if it's super relevant, but when we increased the mass testing to 5,000 per day, it looked like the fatality rate went down. Did I catch that?
Yes, the number of people who died from coronavirus was reduced. That is correct. Not the fatality rate. The number of people by the final time who have died from coronavirus was decreased. Yeah.
People who died.
Yeah.
Okay.
So, and that's different than the fatality rate. The fatality rate, the case fatality rate, for each case who's admitted to the hospital, the probability that they die rather than being successfully discharged from the hospital is the same. What's different is there's a lot fewer people arriving at the hospital needing care. And this induces, in turn, a reduction in the deaths from coronavirus, okay? And that's something which follows through. So we're dealing here not with the fatality rate. We're dealing instead with the number of people cumulatively, the cumulative mortality count, okay?
Okay.
Yeah. And so, good question. You will actually find a case fatality rate within this model, although I won't go into it right now, that is still applied, and that's constant. But that isn't affected, that isn't posited to be affected by that intervention. Okay? So, good question. So I've just placed a scenario in called 20% reduction in mixing here. But I haven't yet put that into effect. I changed the number of individuals mass tested per day back to 0. Note that the number of external individuals arriving per day is back to its original value of 1,000. What I want to do to simulate this reduction mixing is I want to go over to this variable that's highlighted here in green. That's in the upper left of the model. And I'm going to click on it, click on this arrow just below it here, and I'm going to change it to 0.2. 0.2 being the equivalent of 20%. And I'm going to say, okay. Now, what you'll see here appear is the results of this new scenario. So I've reduced mixing of individuals in the population by 20% here. Just drawing on what we've been doing, how does that affect the number of, I've double-clicked on this infective individual symptomatic. I'm going to graph it. How did that change things? So what we're dealing with here is this gray curve. Hopefully you can see my mouse. Can you see my mouse right now? Is my mouse visible?
Yes.
Okay, good. So how does that compare with the baseline? All that differed between the baseline, the blue, and this gray curve is the assumption about a reduced mixing rate that obtains for the gray curve. How did that change things? Can anyone say? In terms of the number of people who are symptomatic at any one time and remain undiagnosed, how did that change things?
A drastic reduction.
Yeah, it reduced the curve. It reduced the peak, the size of the peak. The maximum number of people who are symptomatic at any one time has gone down from something approaching probably around 140,000 to something closer to 75,000. That's a big change. Does it change the timing of that peak? Anyone?
Yes.
Most emphatically so. Most emphatically so, ladies and gentlemen. It's delayed it. It's deferred it by quite a bit. In fact, it bought us even more time than reducing the number of incoming infectives arriving, say, via international travel did. That bought us some number of weeks to better prepare our surge plans, etc., which is exactly what the first part of our work for the health authority involved advising on. And it's exactly on the basis of that they work to establish surge planning using model results. But this reduction in mixing bought even more time, and it lowered the curve. So we might ask, well, what's the broader consequence of that? For example, in terms of the number of people in the hospital, how is that affected? Well, if you double-click on hospital and you go view that, it's reduced the peak number of people in the hospital down from almost exactly 2,250 down to something closer to just over 1,000, probably around 1,100 or so. So that's pretty significant when you consider our hospital capacity. It's also spread it out. This is a so-called flattening of the curve. It's spread it out over a long period of time. In terms of cumulative infections, is it just a matter that we defer the infections? No, we've actually reduced the number of people who get infected from most of the way upwards towards 1 million to somewhere over 750,000 here with that 20% reduction. Of the number of people who died, it's been also strongly decreased by this. We see the ripple through consequences of that. Okay, let's suppose now we were to be encouraged by this and we want to see what's the effect of a 40% reduction in mixing. Maybe it will bring it down by another similar factor, for example. So I just said 40%. I'm going to click on this and change this to 0.4. Now, where has that scenario gone? I'll plot it out here. Where has that gone? I've changed it to a 40% mixing. Can anyone see it on the screen? Which of these curves is not like the other? I'll give you a hint. The peak is not even on the screen. Where is it?
That really flat one at the very
bottom
right.
Exactly. It's growing, but it's growing very, very slowly, and its peak doesn't even occur in this first year. Okay? 40% mixing, it's not merely that it reduces it proportionally and smaller. There's a nonlinear model, and what you'll see is the result of that. The consequences of this are pretty profound. Sometimes decreasing, to a certain point makes a disproportionate difference. Okay, but how if we model a situation where the public has a certain limited patience with social distancing? Or maybe, as is so common in the U.S., there's a precipitous and unwise relaxation of measures before the job is done. How might that affect things? Well, let's leave it at this same 40% change, but you'll see there's this parameter time of behavioral change ceases. We're going to start using that. So I'm going to say 40% reduction in mixing for first 4 months, okay? First 4 months. And we're going to leave this 40% reduction in mixing here, but I'm going to change it from the time at which it ceases from a time that's way off the time horizon, 10,000, to, I'm going to change it to 4 months. So it'll be 4 times 30, 120 days, okay? What do you think you expect to see? What would you see for this? So what we saw with reducing it to 40% of it, reducing it by 40%, was rendering it into this curve that's still going off the top there. Now suppose we do that for the first bunch, but then we release it and let it go back to normal after 4 months. What do you think would happen? Anyone? Well, fortunately with simulation models, we don't have to just muse about it. Muse on the basis of mental models where my mental model is different than yours, is different than Krisha's, and we can't easily see what each other's thinking. Fortunately, we have computers which are really good at doing lots of dumb things quickly, like telling us what the logical consequences are of a precisely articulated theory as captured in a model. So we don't need to speculate at this. Computers are really good at finding the logical consequences of these sort of quantitative assumptions. Let's plug it in and see what figures. So I'm going to say 120 here, and there we go. Okay. So I'm going to double click on this symptomatic Y, the number of undiagnosed symptomatic individuals, and plot it out here. Where is this curve? Well, and excuse me, this is troubling me. So what you'll see here is there's a black curve, which was it where it stayed, it stuck, the 40% reduction mixing for a year. That's a hard thing to sell. It's a hard thing to sell economically, politically. It's hard in this world to get credit for preventing fires that never happen. If you prevent a big outbreak through good planning, and I would add through modeling, it's hard to convince people what's been gained because they don't see the cases that otherwise would have occurred. So if you have a commitment early on, maybe for 4 months, for the first 120 or so days here, and then you see a relaxation of that commitment and things go back to normal, that's this curve here. What's been the net effect? Can anyone say those 4 months of reduced activity? What have they bought us? If we compare this peak with the blue peak. This peak had a 40% reduction mixing adhered to for the first 4 months, but then a relaxation. Blue peak, we didn't put any interventions into effect. What's the difference?
Basically the same peak, just delayed.
Delayed time. Yeah, it's delayed. It's delayed. Okay, now let's focus on a control effort. I think you're getting some of the flavor of this. Let's not start this 40% reduction up front. Maybe we do 40% reduction after let's say 3 months. Okay. Duration remains let's say 4 months. Okay. And we'll say duration 4 months. So we're gonna put in place this reduction in mixing starting not at time 0, but at time, after 3 months. That's time 3 times 30, or about 90. So I'm going to say 90 here. We're going to start this at time 90. Before that, it's business as usual. No intervention. Time 90, wham! We start putting into effect this intervention. And it needs to hold for 4 months. So 90 plus 120 is 210. So I'm going to put in here 210. So its duration is 210. Okay? There we go. Okay. So, ladies and gentlemen, I'm going to go to our outputs. And we see the new curve is the blue one. Can anyone tell me, give me a story, give me a narrative. What happened with this light blue curve? Remember, it's identical before time 120. Before time 90, 3 months in. Before that, it's identical to the dark blue curve. Identical. There's no interventions in place prior to time 90. What happens after time 90 with the light blue compared to the dark blue?
The social distancing starts?
Yes, social distancing starts. Does it still grow?
Slightly.
Slightly. It grows slightly, but then it starts to come down. And there's a natural sort of time constant associated with this. If there were cases built up before, that people infected before that need to recover, and it's going to transmit a bit, but not too effectively, and eventually the number of people recovering per week exceeds the number of people getting the infection per week, and it starts going down. But what gives later? What's going on later? Well, remember, at time 210, something happened. We instituted the infection at time 90, and it lasted for 4 months. That brought us to time 210. What happened after time 210? Well, we relaxed it. We went back to business as usual. Went back to our earlier level of circulation. What happens then? Anyone? Well, what happens then is it rebounds. Does it rebound to the same level that you would see with the original blue? Or the dark blue? No. It doesn't rebound to that level, but it does rebound, and it rises for a while, well above the original peak, only to then decline. We've sort of spread out some cases here, and we did so by bending the curve here with our early behavior change, starting at time 90. We brought it down, and then we relaxed it. And because we had these earlier cases, it strains susceptible some, and we get this rebound to a lower peak, and then it starts declining. Okay? We can, of course, go look at these sort of things for their consequences on other parts of the system. For example, yes, question?
Yeah, I have another question. Sorry.
Sure.
That second wave, because I hear a lot about that in the media, is that sort of based on an assumption about immunity to the virus? If it comes with, so that people are infected, they've developed immunity, and do we know how long?
So,
does that make sense?
So, yes, it's a good question. That is a scenario which some have examined. It's a scenario we have examined for our MHOs in the province, for example, in advising on outbreaks, etc. But that's not the primary assumption behind a second wave. That is something that can lead to multiple waves. But second waves can be led to by many, many types of factors. This is a so-called second wave that has nothing to do with loss of immunity. People within this model, actually, and I'm grateful to the questioner for bringing this up, people within this model remain forever immune. This model, remember, these models sort of are, they operationalize theory. They capture a theory that we posit about the world. And in this case, the theory holds that once someone's infected and recovers, they don't go anywhere. This is, as we say, entrapping state. Like, they become recovered and they stay recovered. They never develop infection again. But we still see the second wave. And why do we see the second wave? Well, it's due to a behavioral change coming out of isolation. People now exhibit greater degrees of contact patterns, and that will very likely, it does in the model, and it will very likely within our province, by late fall at the latest, lead to a second wave. And that second wave may be larger, I'm sorry to say, than the first wave. So that's another reason we may see a second wave. Loss of immunity is one, and it can lead to that effect, but we don't posit it, and that's not the dominant theory right now. There is questions about how quickly the bug mutates, and perhaps like other types of coronaviruses, in flu, it will mutate very quickly. Flu mutates quicker than just about every bug except for HIV, I'm told by immunologists, and that can lead to second waves. But second waves don't require it. They can be due to behavior change, such as here. They can also be due to virus spreading between different jurisdictions. Every year we get waves of the flu, and it's not just because of mutation. It's because the flu lives during other parts of the year, for example, in the southern hemisphere, and it travels north with the winter, and it's brought back in planes from Australia, New Zealand, etc. And so it is with waves as well. The fact is the first wave here in Canada has infected a comparatively small fraction of the population, particularly in our province. And we can expect the likelihood of a second wave unless exquisite management is undertaken. And we're doing everything we can to provide that exquisite management day to day at a tactical, operational, and strategic level. So good question about waves. So just so I can get on to the slides, I will note that these waves are things that apply for the hospitalized population, and there are certainly things that our acute care colleagues within the health authority have a strong interest in. It also has implications for cumulative deaths, for example, where we see a slow rise of deaths early on and then a faster rise later, for example. So here we're seeing the use of a model to explore different what-if scenarios. These scenarios take a model which operationalizes theory and allows us to question the assumptions and to ask, what if this were different? What if that were different? Often in ways that are counterfactual. We don't have the luxury of having observed them before. We're considering new policy regimes, new intervention types, launching an app in Saskatchewan for contact tracing, or helping to put in place better measures for door-to-door screening, or enhancing the size of our contact tracing workforce, or putting into place more effective screening for our long-term care facilities. All of these are things that we've done scenarios on, and these are exactly the sort of scenarios we play out for our health authority, for our Ministry of Health, on a week-by-week basis. You've seen this with a toyish model. This model is not a current model of coronavirus. This is not the model we use day to day to advise our policymakers. It's a much scaled down, simplified one that reflects understanding as it might have been a couple months ago. In no place here is the oligosymptomatic or pouchy symptomatic pathway. We don't have in place, for example, detailed representation of contact tracing, nor do we have a representation of differential transmittivity by asymptomatics. But a model like this should communicate, simple though it is, should communicate some of the power, some of the ways in which these models can be used. Used to ask what might be coming, used to ask what-if questions about possible intervention regimes, or things outside of our control involving, say, the arrival of infectious individuals after reopening of the border, and assess how the consequences you might expect to see reflect those things. A model like this can also help us to be able to run a model like this, also helps us spot when we're off base by allowing us to put together our assumptions under one roof, assumptions about a whole bunch of different factors, the efficiency of contact tracing, the degree to which individuals stay persistently oligosymptomatic, the mean latent period, etc. A model like this can let us assess that model by asking, to what degree does this model reproduce what we see in the population? And it lets us take a hypothesized theory, a theory that we've advanced in an operational way, and test it against, ladies and gentlemen, the crucible of evidence that we have collected. And we may find it wanting, and we can zero in on why it might be wanting and improve that aspect of a model. In short, models like this provide us a quicker, deeper, more reliable way to learn from evidence by taking evidence about the world. Perhaps, for example, it's the number of individuals being hospitalized each day. We compare what comes out of a model scenario for the baseline with what we've actually been put into place, and compare what the model expects the number of hospitalized people should be over time versus what actually is the case, or the number of people seeking care, presenting for care more generally. And it can allow us, by testing the degree to which our theory is consistent with these lines of evidence, not just one line, but many lines. It allows us to test that theory and identify where it needs to be improved. It lets us more quickly identify the errors in our thinking and our understanding of the world so that we can move towards better understanding of the world. So it's very important, ladies and gentlemen, as I go through these slides with you, for you to remember this principle. A model like this might seem a bit like a crystal ball, telling us how many hospitalized to expect. In fact, that's a poor way to view it. That does it a disservice, and it doesn't point to its full potential. A model like this is better viewed as a learning prosthesis, a prosthetic that helps us learn more quickly from evidence and more quickly identify when our thinking is off base. It's not so much a tool in which our faith is due, that we put our confidence in. Rather, a model serves as a way to test out theories and to more quickly refine those theories by identifying more quickly when they're off base, and to use that theory then to understand the evidence, to explicate what's going on within our population. It helps us learn, again, more deeply, more quickly, and indeed more reliably from evidence that's available by providing us the sandbox to test out our thinking. To identify thinking that's off base, thinking that just doesn't line up with the evidence despite our cherished prejudices, and to identify thinking that is more solid, that is consistent with all the evidence that we know, and is due extra confidence. So that's the role of models, not crystal balls, but rather learning prostheses. Prostheses, just like a crutch, helps us maneuver at full capacity despite our physical limitations. A model helps us maneuver at more full capacity despite our cognitive limitations. A lot there, but I want to move on to the slides. So I hope you'll forgive me. Any final question or two before I dive into the slides here that will provide you a conceptual foundation for understanding the buzzing, blooming confusion to which you have just been subjected? Okay, your heads may be buzzing a bit too much, so we'll jump into the slides here. We're going to be going through some motivations for mathematical modeling, mathematical and computational modeling. We're going to be discussing a couple types of mathematical models, and we're going to be taking a look at, as time allows, building a mathematical model, mathematical computational model, which is just what you've seen. Okay, so the motivation for this work, for me and for many practitioners, lies in confronting ever more complex health policy challenges. These include the many challenges that afflict us with COVID, many of which are pointed to by the comments here, but other areas as well. We have mutually interacting conditions. COVID is interacting in a terrifying way with our opioids epidemic, for example, with substance abuse within our province and more broadly within Canada. Some of those most at risk are those of COVID are those with mental health challenges, those with comorbid conditions such as diabetes and chronic heart disease and respiratory problems such as COPD. Health disparities play a key role here. Disparities associated with social determinants of health, such as housing, are important shapers of COVID burdens. And we could go on and on. We have challenges in COVID that are a microcosm of challenges more broadly across our system, and highlight challenges in the public health area, as well as in the fragmentation of our healthcare system more particularly. Now, what unites all these challenges across conditions, across pathogens and diseases, is the fact that they reflect the challenges of complex systems. A system that is in a technical sense complex, in the sense that its behavior is different than its parts. The behavior of the whole is different than its parts. And these sorts of systems are well known in the technical sphere, but awareness of them is really only slowly grown within the health sphere. These systems tend to behave in surprising ways. They react surprisingly and indeed pervasively to interventions. We poke at one place, it pops out somewhere else. For example, we engage in faster case finding through mass testing. It's going to impact not just the number of new cases found, but the number of people hospitalized, the number of people dying from COVID, the number of new cases getting infected on a per-day basis. When we poke, often the link between cause and effect are unclear, as often there's big delays, and there's many types of impacts across the system, and there's reciprocal feedbacks, and they're nonlinear. So we see within infectious disease sphere, as your other work may have pointed, a lot of complexity, but regularities, patterns that we see recurring. Here shown with childhood infectious disease, an area where we've done a great deal of work, and diseases such as chickenpox, measles, pertussis, etc. Here we have cases of measles, for example, in England and Wales, and we have bubonic plague, as noted from the 1700s. Newton was an early observer. We see patterns emerging in zoonoses, such as with rabies, for example, where there's patterns of spatial spread. We see that in chronic wasting disease among cervids within our province, amongst deer. There's many complexities in interpreting the data, delays associated with data, interactions with different types of conditions, feedbacks involving many different factors, including risk perception, which plays such a big role in COVID in shaping personal protective behavior, social distancing, etc. Systems here are nonlinear, and often there's marked differences in the gains from changing one thing versus changing another. Or by changing just a little bit more, we may push the system over a tipping point into a better context. Or adversely, by opening up too quickly, put it into a spiral of terrifying proportions, as is playing out even as we speak in some of the states in the U.S. Within this context, often we get effects of heterogeneity where almost the tail wags the dog. Small groups within the system can have disproportionate impacts. For example, we see heterogeneities in the contact rates associated with sexually transmitted infection that are not just they consist of a small segment of the population, but they have disproportionate impact in the sense they keep the infection alive in the population when it otherwise would have died out. There are effects of scales. We may see very different effects, for example, at the neighborhood, city, provincial, and national level. And often interventions performed early, I didn't have time to show you this interactively with the model, but interactions performed early may be able to catalyze a much greater economy, much greater savings than the same intervention enacted too late, or enacted later because of lock-in effects. Now, there's two big challenges I want to highlight here. One challenge is just, and this may seem overstating it, but it's not. Having worked in this area for so long, and I can tell you, working full-time right now for our health system on COVID, it is far from an exaggeration to say that often we have keen challenges in understanding from data what's going on in a system. Asking, what is this data telling us? Why are we seeing this rise of cases? Is it predominantly driven by new incidents or predominantly driven just by higher rates of testing? Where is it likely to go next? What's driving this? Is what I'm seeing a good or bad indication? Take COVID-19 in New York, for example. Here we had, over time, some number of cases. Those are the brown shown here. Those are the number of new cases per day. You see that it went up, plateaued, and came down. Not unlike those curves we saw just minutes ago. Beyond this, we have a graph of hospitalized, obviously on a different scale. We have a characterization of the number of tests performed per day. That's the black here, new tests per day. And we have a test positivity rate shown here in the sort of orange color. There's also some associated with ICU use and ventilation. This data is telling us something, but understanding what it's telling us is challenging. None of this is a solitude from anything else. The number of tests surely are impacting the number of new cases found per day. The number of new cases found per day is telling us something about the underlying occurrence of infection that's affecting positivity of tests, for example. And surely as we do more tests, many more tests, we'll probably get lower positivity rates because we're testing less risky individuals. The number of people who are in hospital right now are a reflection of new cases, but they're also a reflection of past cases because people might stay in the hospital for a couple of weeks, for example, in ICU. All this data is, in short, intertwined. It's entangled in a way that makes understanding one thing difficult from understanding the other, and almost begs for explanation of, what's going on here? Why do we see these patterns? A lot of the challenges here is, we might have a theory for what's going on in the world, for example. We might have a theory for what's happening behind this. But if we're just depending on informal reasoning, it's hard for us in our head to square with, hey, does that account for all these patterns? If I posited this sort of natural history of COVID, or this sort of attitude towards care seeking, that a lot of people in New York couldn't seek care because they lacked the health insurance coverage needed to do so, tragically. If that was part of my theory, and I want to say, does that account for these patterns? It's kind of hard to do in my head by itself. Sometimes even interpreting results is hard. For example, maybe we see results of declining number of cases per 100,000 for chlamydia in the late 1990s. And we say, okay, we're making great progress through STI testing, contact tracing, etc. But then we look at subsequent years and we see rising rates of chlamydia. Now, are those rising rates a crisis reflecting growing incidents to which we need to respond urgently with the strongest of measures? Or are they, by contrast, ladies and gentlemen, a reflection of a success in care and case finding? Are they the result of more savvy case finding that is in, forgive the term, draining the swamp of infectives. It's going out and finding cases where we weren't finding them previously. Is this a result of larger amounts of testing, merely an artifact of larger amounts of testing rather than a sign of an incipient crisis? Interpreting data like this, just like with this COVID data, is challenging when we do it in our head. What's even more challenging, ladies and gentlemen, is the need to reason about interventions. And this need, as we all know, is pervasive and foundational within the public health sphere. Because public health is about bending the curve. It's shaping our future health state in a better way so that we can enjoy a better health future. And in this sphere, there's many practical questions that confront us, many forks in the road that we have to choose between with limited resources. Do we invest in upstream case finding? Do we invest in faster contact tracing? Where do we best intervene? Which target groups? How to intervene? Through what mechanism? Through encouraging mask use? Through shutting down the schools and workplaces? To what degree do we, institute broader testing within schools to allow them to reopen? To what degree are we going to conceive of broader interventions like door-to-door screening or mass screening? How soon should I see effects? How do I scale it up or scale down from Saskatoon to Maple Creek, where there's an incipient outbreak right now? How do I translate results that have been successful in an urban context to La Loche Clearwater in the north? How do I make this implementation financially sustainable? These are challenges that confront us every day. And the complexities we've been talking about, these delays, nonlinearities, feedbacks, these presence of these tipping points really matter for intervention selection, for identifying which interventions are best. This is complicated a lot by the fact we're dealing with complex systems. These are nonlinear systems, often combining together two policies. Like within this model, we examine the effects of policies independently. In point of fact, for our public health office, our chief medical officer's office for COVID, we examine portfolios of policies. We have in place complementary strategies. For example, perhaps in an outbreak response, aggressive case finding and community cohorting to avoid people having to go back to crowded households. We have complementary policies. But combining two policies, if we consider the benefits from each in isolation and then consider the benefits from combining them, the benefits from combining them can often be very different than the sum of the benefits of each in isolation. There's synergies and there's dynergies. There's ways they work across purposes or duplicate each other in ways that don't yield a much added effect. Nonlinearity is seen in the form of tipping points. We all know the effects of vaccination with herd immunity. Vaccinating just one more family can drive a circulating infection out of the population in the right context. It's a tipping point, and tipping points make all the world of difference. Sometimes intervening early can make a big difference. Sometimes individuals, this is for some of our TB work over a decade ago with TB control here in Saskatchewan, where the roles of bridging individuals were identified who can have disproportionate impact on it and can knit together communities in ways that can bring TB back and forth between the community. And we talked earlier about heterogeneity, where individuals, for example, with a large number of sexual partners or gatherings that are particularly large, high duration, involve high risk activities like singing, etc., can serve as superhighways for infection. Here, not only are we dealing with the challenges we saw earlier, where we have a theory and we want to understand the degree to which it's consistent with evidence, but here we're seeking desired outcomes and we're considering possible interventions that will change things in the world And we want to know, for our theory of the world, sort of how the natural history of infection takes place and what motivates people to seek care or what have you with COVID. We have to consider in the context of interventions that layer on changes, and we want to see the desired outcomes and find desired outcomes that are most efficacious, that are highest leverage, for example, or most cost effective. Within this sphere, relying on informal reasoning, ladies and gentlemen, is a fool's errand. It's a profoundly challenging task. And studies have shown that even with modestly complex systems, even the most highly savvy type of individual conceptually makes very fundamental mistakes. And ladies and gentlemen, the consequences of these mistakes are writ large over the history of poorly defined responses to infectious diseases and other challenges in the health sphere. Policy resistance, a policy that's launched perhaps to great fanfare or with strong resourcing, which doesn't secure traction. There's difficulties learning from experience, getting actors in different areas of our system, public health, acute care, for example, to coordinate with each other, coordinate with social services, corrections and policing, etc. Challenges with planning and deciding, investing in policy portfolios, and designing things. Now, reductionist attempts, which do include many of the traditional methods in the canon, still continue to exert great value. And the models that you'll be seeing here, and that you've seen some glimpses of, work very well with traditional approaches. But reductionist approaches on their own, and I would include in there, for example, regression-type approaches, etc., are frankly simply not sufficient for dealing with complex systems on their own. We need a broader toolbox where those traditional methods, valuable they are complemented by other techniques. And this is a reflection in large part because traditional techniques have pursued strategies that are fundamentally reductionist. They take pieces apart and they seek to understand the whole by understanding the pieces. But when we're dealing with systems that are complex systems, I defined them early on in this talk as systems where the whole is different than the sum of the parts. They're not accounted for by the pieces in isolation any more than a traffic jam's behavior it can be predicted by knowing a world about each car model type and engine type and tire type. That doesn't tell you about a traffic jam. A traffic jam is a different sort of phenomenon. It's a higher level phenomenon. It's a systems phenomenon that transcends the pieces out of which the traffic jam is made. And so it is with our healthcare systems. We can know all the world about each little piece, but know next to nothing about the behavior of all of them working together. And reductionist attempts, reductionist approaches really fall short in confronting some of these challenges left to their own devices. When it goes from going to an individual level to the meso level, the macro level, reasoning about how individual behavior shapes macro outcomes. While we have things like multi-level modeling and so on regression-wise, these are still fundamental ways of taking some overall effect and parceling it out neatly in non-overlapping ways to different types of covariates in ways that give little insight into the causality nor into the reciprocal effects that are in place. And when we have reciprocal causality, nonlinearity, when we have tangled syndemics, and when we have these contexts where we have different levels of scale, we need methods that are up to addressing the complexities at that level to get in place fixes that stay fixed, which won't just roll back on us in a Sisyphusian type way. And there's many challenges for unassisted techniques. In longer versions of this presentation, I'll go through a litany of past examples of cases of systems effects biting us back. Examples include things like antimicrobial resistance. More we treat, more we use it as part of routine industrial agriculture, the more AMR crops up, and the greater the difficulties managing sometimes what were routine infections. We see it in response to past outbreaks such as HIV/AIDS, where stigma associated with it drove people away from early care seeking. We see it in the form of responses to behavioral responses to past outbreaks in North America, such as the 1918 flu, where we had adverse behavioral responses that led to re-exposure of individuals as the disease was decreasing, and exactly that sort of second bound that we saw in our brief introduction to models. In short, I've listed out a dozen others which I could share with you if you were interested. We're dealing, in short, with a situation where we have to deal with more than the pieces. We find ourselves traditionally like blind men with an elephant, arguing about the parts of the elephant, convinced it's the whole, the entirety, when in reality, we need methods that will allow us to deal with the whole elephant, because we're not going to be able to solve the problem of the elephant rampaging our crops by dealing only with its tail, nor with its ear, nor even yet its trunk or tusk. And these, ladies and gentlemen, are the parts of the elephant. They whisper to us of an underlying system that's much broader, but they are just different faces of that system, and a system that has many faces we can't even observe. These are the different parts of the elephant which, if we study in isolation, we've missed the big picture. In other spheres, we get the same thing. We get many types of phenomena we want to explain. In TB, for example, we might look at the historical progress of Saskatchewan against what used to be known as the White Plague from the standpoint of many different time series. And for many years, we've examined this with models to the present day, together with colleagues in respirology these days. To confront these challenges, we need a way of dealing with the whole elephant. And that, ladies and gentlemen, is going to be the focus of our next comments. So the reflection here is these patterns, these time series, these observations, this evidence. These are not solitudes from each other. They whisper, as I said, to us about an underlying system. The language of critical realism and realist philosophy speaks about this, where we talk about context, mechanism, and outcome. And we need to reason about the mechanisms. We're reasoning about an underlying situation that we can't directly observe in all its details. We can only get imperfect measurements of it. But all of what we've seen are different faces of that underlying system, and just the faces that happen to be measurable. And these different parts of the system, these different faces, and indeed often many different health problems, say opioid abuse and the spread of COVID, are interrelated and causally tangled. To understand why some patterns of ill health persist, why we still get outbreaks, for example. Right now, we're working with 2 outbreaks in 2 communities and a third one that may be announced today. We need to work with tools that will allow us to reason about the underlying system presented. And for infectious diseases, for example, these underlying depictions might depict the natural history of infection, mechanisms of infection transmission. Maybe it's airborne alone. Maybe we want to reason about surface-based transmission or fecal-oral in the context of long-term care. We need to reason about the health system response, about risk behaviors and risk perception and demographic change sometimes in the population, depending on the timescales. If this is starting to connect with the model with which we started, it is for good reason. This model depicts natural history of infection of sorts. We have mechanisms of infection transmission, of mixing in the community. We have health system response in terms of mass testing, which identifies individuals whether symptomatic or not. We have in place risk behavior and risk perception and care seeking as a result of it, and as part of the care system response as well. And that's because this model is articulated according to the principles of what's known variously as system science, that's the preferred NIH term, or complexity science, a somewhat older term. I'd rather find both attractive for different reasons. I like to term this the science of the whole. It's about the whole. Recognizing the whole is different than the sum of parts, any more so than, a person is just more than their atoms. System science is a broad set of methods that can help us visualize, understand, and reason about these underlying processes we're dealing with. And they allow us to test, as I indicated earlier with this model, consistency with evidence. Now, system science and complexity science have many tools. And in our lab, our computational epidemiology public health informatics lab, we actually make use of a variety of these tools. But today, we are speaking about dynamic models, a particular type of tool. And those are actually the most prominent, and I would argue the most influential of these tools. Influential on a day-to-day basis within our care system here, within Public Health Agency of Canada, within the WHO, and worldwide. These models weave together a representation of our hypotheses, our sort of theory about how things might work in the world, so that we can understand their logical implications. And they do seek to understand the causal structure of the system, the causal relationships here, what leads to what within the system. I had articulated from this floor an hour ago that models like this can be viewed as operationalized dynamic hypotheses. I'd like to piece that apart. Operationalized because we articulate them at a precise enough level to have their consequences be logically shown to us, to have even a computer understand what we mean, to have it be sufficiently unambiguous that a computer can simulate it. So behind each of these flows lies an equation, such as you see here. They're operationalized. We've made them very particular. They're not inchoate ideas in our head, but crafted in a form that's precise. That doesn't mean accurate necessarily, but it means precise. And by so doing, we'll be able to assess their accuracy. So they're operationalized. They're dynamic. They're about change over time. We are characterizing, for example, how many people become infected if we have a certain number of susceptibles and a certain force of infection. The number of people per day getting infected is the force of infection times the number of susceptibles, where the force of infection is articulated on a per day basis, probably per day. It's a hazard rate of a susceptible will get infected. So these are dynamic models. They deal with behavior over time. And I say hypothesis because we're positing a certain theory concerning the causal structure. This is not the only theory. And indeed, our more recent versions of these models have asymptomatic or oligosymptomatic pathways, paucisymptomatic pathways. But it's a posited theory for the world that we put forward. I term it here a hypothesis concerning the causal structure. And we use that to understand counterfactuals. That's what we ran. That was all these different what-if questions. We asked, what if we did this? What if we did that? We couldn't observe it. It was something which hasn't happened yet. It's a counterfactual. It's something which is different than what's happened. And then we use these to refine our mental models. So models like this have many different uses. And you'll see a broad use of system science methods using these models as boundary objects, as explicit constructs, mostly to share assumptions, to invite critique, to take our hypotheses out of our heads, our theories out of our heads, put them in a way that is in the clear light of day and can be critiqued by others. It takes a certain boldness, but that's how we arrive at a better understanding ourselves and collectively as a society. It's taking them out in a way that can be critiqued and can be precise and where we can test them against evidence. But here we're just speaking about taking them away, it can be examined. So we might, for example, articulate models as model maps initially, where we have some number of undiagnosed infective individuals. They tend to lead, all other things being equal, to new infections, which create more of them. So this is reinforcing vicious cycle here that otherwise goes to create to lead to more and more undiagnosed infective individuals. Fortunately, there are counterbalancing things, and I haven't shown all of them, but one of them is, over time, the more undiagnosed we get, more individuals with a delay. That's what the slashes are presenting for care. That leads to higher test volumes, more new confirmed cases, and by taking those people out of circulation, fewer undiagnosed infective individuals. So we have a balancing loop here that sort of counterbalances what would otherwise be something that's out of control. And then we can get, a virtuous cycle here where we identify more cases through contact tracing, lead to more cases which we trace, and we're chasing them down in a virtuous cycle. This is what's called a model map, and it takes an assumption out of our heads and puts it in a way it can be critiqued, but isn't a runnable model. It's just a kind of depiction, semi-quantitative depiction about how these things fit together. And in our modeling, we use exactly these types of constructs, whether it's this sort of model map or a similar version articulated in a different language, to have group model building sessions where we bring together patient-oriented patients and family advisors, or we bring together experts from a care system to provide feedback. In other cases, we have more structured models. For example, this is one of our more recent COVID models, although not the fully recent one, where we represent, for example, care standard, most familiar pathways of natural history, but also, for example, oligosymptomatic pathways in individuals who are diagnosed, for example, shown with these Ds. So individuals who are no longer circulating as broadly, we hope. We can depict models using stocks and flows for many types of conditions. This is for TB, for example, where there's a long latent state. Or for zoonoses such as West Nile, where we have, for example, birds, mosquitoes, and people, and where the mosquitoes bite the people and the mosquitoes bite the birds, and there's transmission back and forth with birds as a reservoir species. Sometimes we have models articulated at a finer grained level. For example, in so-called agent-based or individual-based modeling, we have models that are articulated at individual level. This is for chronic wasting disease, built with Cheryl Waldner, esteemed epidemiologist and public health practitioner, and indeed modeler here at the U of S. This was one of the earlier works where we worked together with chronic wasting disease, and what you actually see here is movement patterns for deer and natural history of infection for deer. Now, models as boundary objects are useful. They allow us to put this in front of people and say, what am I missing? Critique it. Help me understand what I need to add to it to make it more believable or more credible according to your best understanding. That's very useful. But ladies and gentlemen, with dynamic modeling in general, most commonly, and with this sort of modeling we saw at first, we take it one step further. Not only are these nice diagrams that illustrate in a graphical form some of our assumptions, they are operationalized at a level, at a precise enough level, they allow us to simulate it. And with simulation, these models can tell us their logical consequences. They could tell us what's the implication if this is how we think things are in the world, and we believe that we've described it pretty well, what behavior should we see over time? That's exactly what we saw earlier, right? With respect to things like prevalence in the community, or with respect to things like the number of undiagnosed symptomatics. This is the behavior over time induced by this model, albeit with some altered assumptions about certain things, certain what-if situations. So why do we build these models? Well, they help us and other system actors to understand the system vulnerability and leverage points where we can intervene most fruitfully, where we can change model structure, how we can do things better going forward, and improve ways of getting people, for example, on the corrections and policing system working better more effectively with public health, or social services and public health, making sure social workers can help deal with some of the mental health and addictions challenges that pose enormous challenges with social distancing and isolation and quarantining for COVID, for example. And with simulation, what it allows us to do is what we saw in the opening, buzzing, blooming confusion of this very lecture. We can take a model and we simulate it. And by simulating, we get behavior over time with respect to different pieces of the model. Behavior over time of hospitalized, for example, or behavior over time of the number of undiagnosed symptomatic individuals, of the number of people per day becoming newly infected, of the number over time dying from coronavirus. All of those are things we can simulate. And that's what we do with simulation with these dynamic models. They go from being merely instructive, insightful, revealing pictures that lay bare our assumptions for critique into things that can tell us about surprising behavior, and where we can use to anticipate what's coming, spot where our understanding is off base from empirical evidence, and ask what-if questions. So we could see behavior over time, or we could see behavior over space, for example, with certain sorts of models. What sort of distribution of pathogen might we expect to see here with chronic wasting disease? Here, each of these little figurines is a white-tailed deer, and those allow us to understand the implications of the models in ways that it would be prohibitive in our head. So, what are these dynamic models? And what is this thing? Well, it goes by different names, and it's kind of dizzying how the literature refers to these, the number of different names they carry. Some of the most common names are mathematical models, computational models, but those are rather blunt terms because they don't explicitly refer to dynamic model. I like dynamic model because it implies it's a model over time. Computational mathematical is not so specific. Occasionally you'll hear them termed causal model, but that's confusing because there's another set of causal modeling tradition within statistics, which is distantly related but different. They go by many names of different sub areas: system dynamics model, compartmental modeling, mechanistic modeling, agent-based modeling, individual-based modeling, microsimulation modeling, discrete event simulation, discrete event modeling. These are all words that point to either the general class or, for most of them, specific sub-areas of dynamic modeling. What unites all of these is basically they examine dynamic behavior over time is on the x-axis, resulting from hypothesized causal structure. That is what is in front of you here. What thing leads to what? We could add a separate oligosymptomatic pathway. That would be another aspect of structure I could add, and I would say, what would the behavior, and I can assure you, the behavior for hospitalized, the behavior for the number of cases found over time, or the number of cumulative infections would be different. So they let us take causal structure and say, what is the implication? Go figure, tell me what the logical implications of this is. And these models do so in a generative way. They kind of depict the physics of the system. What's going on out there? That's what this depicts. It's a depiction of what's going on out there in the world, what we hypothesize to go on. Not because we know it's right, but because so hypothesizing we can more quickly find out if we're off base. And they simulate, step by step, the evolution of the state of the system over time. It occurs so quickly here, you didn't even see it. It was something which occurs so quickly that you don't even have the ability to sort of stop it. But there are versions of this where you can step it, sort of time point by time point, step it out, and this allows us to basically play out over time what's going on a step-by-step basis. And this is how it's simulated. Step by step, it simulates how many people are here, 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 here. And then it figures out how many people go between them in the next day. And then the next day, how many people are here, 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 etc. And then figures out how many people go between these stocks that day, how many people are coming in externally. And it plots it out. It's simulating, as in this micro world, what's going on over time. And because we're positing causal structure of the system, we can ask about these counterfactuals. So a model here depicts the behavior of the system over time. There's an evolving state. Each of these are elements of the state, and over time, we get an evolution of those elements of the state here for different scenarios. And the models specify how do things change given the current state. I started by saying this is a dynamic system. Whoa, I didn't mean to do that, sorry. This is a dynamic system. It's a system whose behavior at any one time depends on its current situation. So the number of people, for example, becoming infected depends on the number of people who are susceptible. The number of people getting newly infected in a given day depends on the number of people susceptible. If there's 1 million people susceptible, there'll be more people getting infected, chances are, than if there's 10 people still susceptible. And if there's 0 people susceptible, no matter what you multiply 0 by, it's going to be 0 people getting infected per day. So given the current state there, like the number of people susceptible, they'll specify how many people will get infected in this next little bit. The system behavior here as a whole, I haven't programmed in. Ladies and gentlemen, until I run this model, I don't know what this is going to look like. I may have a PhD in applied math and computer science, but I can't anticipate. And in fact, I would defy anyone in the world to anticipate what most of these models look like over time in their head. It's not something we are set up to do as part of our wetware. Instead, it's an emergent property that needs to be computed by something that's up to task, something called a computer. Okay? So we can't pre-specify this in closed form. We can't specify a formula for how this is going to change over time. That results from how many people are coming in here, how many people are going out there, how many people are being found through testing, number of deaths that occurred, and number of people coming in here. And it's the computer's job to sort of solve this for us, to tell us how this changes over time. In general, you cannot write down. Mathematics does not have the language to write down formulae in so-called enclosed form, a formula that specifies how that changes. In that sense, it's very different from something like a logistic regression, where you write down exactly that, and even a regression over time. It's totally different. It's a different type of model completely. You can't write it down over time. these models, just like the systems they characterize, are generally dynamic models. Generally nonlinear. Okay, so what are in these models for infectious diseases? What do we put in these models? Well, commonly for an infectious disease context or a communicable disease context, we'll include infection. We may include impacts of various interventions. Maybe it's active case finding, prophylaxis such as masks, or for STIs, it would be use of condoms, social distancing, perhaps in the case of airborne or moisture droplet-based spread, etc. What's sometimes included are things like preferential mixing. Kids mix more with kids. They have more contacts with kids, for example, proportionally than adults do. Variability in contacts, heterogeneity in contacts, health services interactions, for example, treatment pathways. Here we have a hospital. A lot of communicable disease models don't have that. Sometimes, like more sophisticated models we've built have many compartments. So they have, hospitalized non-ICU, hospitalized ICU, etc. Changes in behavior, risk perception, or attitude are sometimes included. And sometimes even, and we've done a lot of work with this, immune response. So why do you build models like this? Well, sometimes I ask people in health, why don't you build models like this? Because, look, in countless other spheres of modern society, of skilled areas of practice, we rely on simulation as a matter of course. For training a pilot, you would never want to fly in a plane flown by a pilot who has not had the experience of flying through a thunderstorm. Now, you don't want to give them that experience by flying a $300 million plane through a thunderstorm. What you do is you set them up in a flight simulator, which throws all sorts of adverse conditions at them, and they learn how the plane behaves under those adverse conditions. It's similar with process and power plants. We don't wait for an emergency to occur to train people in how to respond to those emergencies and to what will happen. Same thing with street design and traffic flow. For climate policy, we have climate models. Countless different areas, we rely on models. Driving simulators, right? For driver training. What roles do these play? Well, coming back to some of those challenges we saw earlier, look, so much of our challenges in public health lie in making sense of this diverse evidence. Trying to turn this sort of evidence, or this sort of evidence, into some understanding about what's going on out there, some theory. And if we rely on informal reasoning, I argue that's very hard to do, to piece it all together in our heads. With a simulation model, we directly address that step. We put in a theory in the model, precise enough to be simulated, and we can then see, does it jibe with empirical observations, and does it explain the most salient of them I'm interested in? When I say precise model, again, I don't mean an accurate model. I'm not positing that this is an accurate depiction of the situation. In fact, I don't think it is. In fact, I know it's not. But it's a working hypothesis. We put in there as, could it be this way? And we see the consequences of it. Similarly, for interventions, if we rely on informal reasoning, trying to figure out what dynamics are implied by what's going on out there in the world in intervention is devilishly complicated. I defy anyone to do it reliably, to do it for a broad set of interventions in their head. It's madness. But we as a society commonly do that. We walk around with mental models that are stuck in our heads that we can't show to other people, communicate to other people, we can't simulate exactly, and we make decisions based on them. And in my view, and a lot of the times, it's madness. Instead, what models do is they take us out of the sphere of informal reasoning, and they basically allow us a principled way to be precise about our assumptions, about our theory, and to ask our questions about the interventions in a consistent way, and to, with strong consistency, guaranteed by the dumbness of computers and executing certain rules again and again and again, what are the consequences? To what degree do they affect various empirical indicators? What will we expect to see with this intervention in place in terms of case counts, in terms of test positivity, in terms of the numbers of individuals requiring ICU care, ventilation, etc.? We can also see the implications of things like health outcomes, cost outcomes, and other implications. So I argued earlier, these are not crystal balls. These are learning prostheses. And I won't go through this again because I think I hit on it strongly. But fundamentally, they help us learn more quickly, more robustly, and more deeply from empirical evidence by testing our theory in the crucible of that evidence. And testing, does it jibe? Does what we see in terms of the induced behavior thus far jibe with what we see empirically? So these are tools. These are mental prostheses that give us something closer to full function. A mechanical prosthesis deals with physical limitations. It lets us achieve more or less something close to full functionality physically, despite a physical limitation, like a loss of a leg. That can offer great benefits within the physical sphere. Mental prostheses do the same here. Our mental matter, our wetware in our heads, is just not up to taking a model like this and saying what if by itself. We need help, just like we do with the physical prostheses. We need something to complement our limitations, and we use a model to do it. And the model, like the prosthesis, is imperfect, but it gets us to refine our mental model so we can make better decisions. And we can test it against observations from the evidence and how things change in the world when we undertake action as a result of the model. And the idea here is, look, we could all sit back and criticize and say, I don't know what this is. Maybe this model is off base. Maybe it's not a good model. That's not very constructive. What is constructive is to put a stake in the sand, to say, look, I'll posit this as a working hypothesis for how things are, and let's test it. Francis Bacon said it in the 1600s. One sooner derives truth from error than from confusion. Sitting back and musing and just saying, I'm not going to put it down because I don't know what to assume, is not fundamentally going to advance you. What will advance you is saying, let's try this. We'll try this on for size as an assumption and test it, again, against this in the crucible of evidence, and then refine it. Find where it's wanting. So here with a model, we have this precise try at it to specify. And we try, and if it's off base in terms of matching up to empirical evidence or some other feature of the situation that may not have strong quantitative evidence, but which system practitioners can attest to, we go modify the model. And this provides a way of replacing confusion by learning. It lets us fail forward in modern expertise. Fail early, fail often, if we put it in 20th century terms. And so even putting forward a poor model often advances knowledge by allowing us to spot these inconsistencies between our assumptions and evidence. So suppose we're working towards a better and better model. And for COVID, we have a handful of these models for our province and for other provinces and for Australia. We're working with partners across the world on this sort of stuff. And what are the uses of these models once they advance? Well, I talked about how they can learn more deeply, more reliably, faster from evidence, and that's a key thing. And they can make explicit our mental models for discussion and collective refinement. Those are two things I hit on. But they also assist in this management of complex situations. They allow us to ask these what-if tools that allow us to say, what is the load on the care system if we do this or do that? And identify potentially policies and collections of portfolios of interventions that are cost-effective, high leverage, and robust. They allow us to evaluate the benefits of restructuring a system, to understand trends and make sense of interaction of all this different data. A model like this, it benefits by having many sorts of data sources informing it, if that is possible. If it's not a showstopper. But if it is possible, it benefits, and it can make sense of all those different facets of the situation, the different faces of the situation. Provide, in short, this coherent picture for what's going on within that explains all these different faces like we saw earlier with COVID. It can help us prioritize data collection, identify inconsistencies in data. Many a time in my modeling, I found the model unable to match some data, and we've gone to the custodians of the data or those who provided it, those who are experts in the system, and they tell us, oh, that's actually a problem with the data source. It's not a problem with your model. We wouldn't have known about that problem with the data source without the model. It told us this is not consistent, and we wouldn't have identified that problem, that's issue with data quality, had we not had that model to point it out to us. And finally, we can understand classes of contexts where certain strategies are best applied. Strategies that work for door-to-door screening in La Loche may not work so well, for example, in Saskatoon. There may be easier adaptation for aspects of the Maple Creek outbreak, for example, or others. Communication. They can serve as learning labs and communicate with communities or other stakeholders. And perhaps most basically, they can support a learning health system and institutional reflection. Ladies and gentlemen, models like this are valuable. But what's even more valuable than the model is the modeling. Because modeling as an activity brings out understanding, knowledge, it forces reflection on the part of the system. And that can identify whole areas of needed investment, whole areas where there's not a consistent understanding, where inconsistent terminology is in place. It's an opportunity for capital investment, in short, that can really help the whole organization. And that was my final point here. But now there's a common misperception, and you find it in many quarters, that undertaking modeling requires extensive evidence about a system. That, look, you can't build a model like this until you have a lot of data. The truth is, that's only a half-truth. What model you build depends on how much information you may have, what model you can build. But there's many uses of models that can flourish without large quantities of data. If you want to understand quantitative trade-offs between different policies portfolios, you do typically require substantial amounts of empirical data. But models that are designed to help us think through how things are interacting and explain why we might see certain effects, or how gatherings of different sizes and densities and levels of mixing associated with different levels of mask use and different levels associated with duration, etc., how those might affect things, that might not require a model that has a lot of empirical data in it. Maybe there's bits, but not much. And some of the most powerful models are the simplest ones. They teach an underlying truth, much as a political cartoon, a caricature, communicates some basic, obvious truth about the situation. But the things that are communicated here are often not obvious, except in retrospect. There are things that have eluded us in our thinking. So models can serve as these formidable learning tools, and they can be sometimes most powerful when there's little data available, and you're engaged in what's called theory building, a term used by Ross Hammond, which I rather like. Now, what are some limitations of models here? There's huge limitations. I like to say, ladies and gentlemen, when it comes to making choices for decision making in health, models are the worst of all methods, except for everything else. It harks back to a quote by Winston Churchill, some of you may know. Democracy is the worst form of government, except for everything else. A given simulation model has big limitations, though, and modeling as a whole has limitations. A given simulation model is typically focused around one or a few defined purposes. It's not something you can use for any old purpose. It's very important when you have a simulation model to know what are its legitimate sphere of use. And it's built for purpose, for certain goals, support certain things and not others. And you want to be very careful about it because the output may look similar to may look similar in what it produces in general terms to another model that's built for a very different purpose. And you can't necessarily assume that they have the same goal. What models you build will be very much shaped by your aims. Ross Hammond speaks about modeling for theory building versus modeling for theory explication. So to the degree that you're trying to build up theory, models can be extremely useful in a very stylized way, in a way that has very little empirical data, or only modest amounts of empirical data. Theory explication requires models that are typically much more grounded empirically. Whether we can engage, for example, modeling for theory explication will depend on, is there good availability of theory? Is the evidence accessible in that area? Model for theory building can be undertaken more generally when we want to build theory. I like to analogize models in the sense that they're fit for purpose, they're built for purpose, to another familiar construct, ladies and gentlemen, maps. All of us will be familiar with maps, and some of those on the call may be young enough to not be able to remember physically carrying around a map in your car. We might have maps of different sorts. And these maps all represent abstractions of the world. They hide lots of details, and they're useful because they hide details. But which details they hide are different depending on the purpose of a map. If we're in Saskatoon and we want to understand how to drive across the city, we'll use one sort of map. If we want to understand, for example, how to bike across the city, a different map will be appropriate. If we want to understand how to take a bus from Place Riel to the airport, we'll use a different map yet, potentially, one that shows bus connections, etc., bus routes. If we want to understand why brownouts are occurring in a certain area of Saskatoon, or indeed why flooding is occurring, we will use different maps yet. Maps are specific to purpose. They may depict aspects of the world, but what aspects they depict and what they hide depends on their purpose. And so it is with models. Which details we omit depends on how we wish to use the model. And you might say, rather uncharitably, that all maps are wrong because they don't depict the full situation in the world. This map, which is a street map of Saskatoon, is wrong. I don't think that's a very fruitful way to look at it. It's an abstraction. It's an approximation. It's a useful approximation for certain things. The famous statistician George Box once said, all models are wrong, some models are useful. And so it is with maps. Maps are useful for certain purposes. Models are useful for certain purposes. They have incompleteness with respect to even those purposes and with respect to other needs, but they can be very useful for certain purposes. And I would note that all of us at some level use models. The question is, do we make those models explicit? Because if we don't, we're relying solely on the province of mental models. Models that are somewhat inchoate in our head, whose logical implications we can't spell out because we haven't articulated the assumptions precisely enough to make it operationalizable. And secondly, even if we could, we can't do those computations in our head. Those are the sorts of models we rely on day to day. And they are especially dangerous because we can't share them easily. We can't expose them to other scrutiny and critique. Simulation models are highly limited, but they can be collectively refined, critiqued, improved, and their implications can be assessed through simulation, through asking what are the logical consequences of this model in terms of quantities about which we care. Okay, one thing that's going to hold for all types of models is a question about model scope. And for this is something which is often missed by people early on when engaging with these models. But it's a very fundamental question. And it's a fundamental question for models of infectious and communicable disease. But it's also an important question for models, dynamic models in other spheres. There are three fundamental areas where you might say that a given factor about the world is treated by a model, or how it's represented by a model. Classes of representation. Some factors in a model are what we call endogenous. They are generated by the model. We don't tell the model these factors. The model tells us what the consequences are in terms of that factor. Hospitalized is an example here. We're not specifying the shape of this curve over time. The model is specifying what is induced on that curve, what is generated, what results for that. Same thing with this number of infectious individuals, Y, or the number of cumulative cases of COVID infection, or the number of the fraction of the mixing community who are infected with the COVID virus. Those are not things that we have put into the model. Rather, they're things the model produces. They're generated by the model. These are the endogenous quantities. There's other quantities that are exogenous. These are specified by us to the model in a pre-specified way. It may be a fixed value, or it may be a time series. We don't have it here, but you could here we, for example, specify a number of external individuals arriving per day. That's 1,000. But maybe we actually know what the volume was of people coming into Saskatoon on a per day basis for the first bunch of months of this fair year of 2020. In which case we could put it in as a time series that would drive this component of the model. It will be used to kind of as a pre-specified input to this model. And you can do that. Maybe it's people, births coming into the model. We know perhaps on a per day basis, or individuals who are being identified as having come in from other provinces or what have you. So some things can be pre-specified as time series, but a lot of things are pre-specified as assumptions in terms of constants. For example, we might have a mean latent period of 2.9 days, or a mean incubation period of 2.6 days. We might have some fraction of care seekers that are admitted to hospital based on empirical data from Canada. These are things we call exogenous. The model's not telling it to us, as was the case with endogenous. We're telling it to the model. We're saying, assume this about the fraction of care seekers admitted to hospital, their case fatality rate for those in the hospital, or the mean latent period. These are exogenous things. And we're saying, go figure based on these assumptions. These are our assumptions. The endogenous things are things generated by the model, and then there's a set of things we've just ignored. There's a lot ignored here. I mentioned the oligosymptomatic pathway. What's another thing ignored? Well, we ignore the fact that there's contact tracing going on explicitly here. We're not capturing that explicitly, that each new case triggers case finding. That's not captured in this model. We're not capturing age differences and differential mixing by age. We're not capturing the fact that some people in the hospital are in ICU and some are not. These are things that are just ignored right now. And it's good to be aware of these and to say these are consciously ignored. It's not necessarily a shortcoming of the model per se. Maybe those are in your parking lot to put in later. But they're things that right now are not considered. And one of the challenges across multiple modeling types, whether agent-based, system dynamics or compartmental like this, or a model based on discrete event simulation, concerns balancing how many things do we try to have be exogenous versus exogenous. Often we're balancing the size of the model versus how quickly we want to build it, etc. Now, I'd like to give you a brief glimpse of multiple strains of modeling or types of modeling. We've seen system dynamics models, and we've actually seen two components of that sort of modeling tradition. One has been these stock and flow models, such as this COVID model here. Another has been these causal loop diagrams. System dynamics is a long-standing methodology for helping to visualize, reason about, and help manage complex systems. And it dates back to the work of the late 1950s by Jay Forrester at MIT. It's come to embrace both quantitative side and a qualitative side, where often the qualitative side is used to communicate with stakeholders before a quantitative model is built, or to provide a sort of shorthand understanding of what's been shown from a quantitative model. System dynamics as a tradition, and I'll come to the cognate tradition of compartmental modeling in a moment, tends to focus on feedbacks as fundamental shapers of behavior. That's why we denote things here using these sort of loops, indicating that there's a feedback in place. For example, someone who's in ill health and may contribute to dysphoria and stress, their impulse towards self-medication, their use of substances, which reduces their nutrition yet further, and that impacts their health adversely and going around. It's a vicious cycle. So here our focus is often on feedbacks and accumulations. We have these accumulations called stocks. We saw them in our model earlier. And then there's going to be feedbacks involving them that we often depict on a causal loop diagram using these sort of indications to polarity, but they're associated with loops in the causal loop diagram. And we emphasize it because they have a first-order impact on the stability of the system, its behavior. And accumulations are causes for inertia, delay, disequilibria. With COVID, for example, there's a marked and very troubling and practically challenging delay between infections on the one hand, way down here, and case presentation way up here. If you look at this, we have these several stocks here. Cases where people are exposed, not yet infective. People are infective, but not yet symptomatic. And it takes time for them to get to the symptomatic state. There's delays associated with each. Once they arrive at the exposed state, they spend 2.9 days on average here. 2.6 days on average here in the infective asymptomatic, for a total of 5.5 days. And then commonly within this state Y, they'll remain some number of days before presenting for care. Complications often take something like 6 days, for example, to emerge. So you total that up, and you're approaching 2 weeks, quite commonly, for people to present for care. What is it that contributes to those long delays? It's the presence of these stalks along the way. You can increase this one. It'll take some time before that ripples through to an increase to this one, increase to that one, in turn an increase to seeking care. These sorts of models admit to formal reasoning and analysis, and stakeholder participation is often quite centrally emphasized in system dynamics. So, for example, in our own work, we work a great deal with patient-oriented researchers, although most certainly in areas also including agent-based modeling I'll come to in a moment, not just system dynamics. But there's a long tradition of it here, of participatory modeling. And it offers these qualitative components, a modeling process that can deliver a lot of insight early on through causal loop diagrams, but ongoing value through quantitative simulation. It also offers time-honed techniques for participatory work with stakeholders, rigorous mathematical foundations, and access to a really rich set of analysis approaches. And the software for it is actually much easier to use than software in some of the other dynamic modeling areas. I don't think we have time to go into this at the level I'd love to, but stocks here represent accumulations. They represent the current state of the system, how many people, for example, are susceptible, infective, or recovered at any one time. And these are changed only by the flows into and out of them. So the only way infective is increased is it's drained through recovereds, for example, here, and it's increased through incidence of new infection. These, as noted, lead to inertia, delays associated with a system. The other major building block of these systems is flows, and that's shown here in red. And these flows basically characterize how many, in this case, it's how many people go from susceptible to infective within a given unit of time. So maybe the unit is day. So just as in our model, how many people go from susceptible to exposed in a day? That's characterized by this flow. And the equation for it is given by the force of infection times the number that are susceptible. Okay? These flows are invariably things like people per unit time, or vaccines delivered per unit time, or dollars per unit time. What you have is this interaction between the two components. At any one time, the stocks collectively determine the values of flows, just like susceptible determines the values of infection here. Okay? The value of number of people in susceptibles determines the value of infection. So it is with the stocks determining the rate of flow across the entire system. How many people flow down here depends on the value of the stock. And so we say that the stocks determine the flows. So for a given day, we figure out, given the force of infection, the number of susceptible, how many people got infected in the next day. And so we do it for the number leaving latency, and the number leaving the incubation period, and the number getting hospitalized, seeking care and getting hospitalized, etc. We do that for all those flows, and then they, if we had 1,000 people susceptible, and we had 10 people in a given day who become newly infected, now we have 990 susceptibles for the next day. And maybe the next day we see, 9 people infected. So now we're down to 981 susceptibles. And meanwhile, the exposed, went up by 10, and now it's gone up by another 9, but it has people going out. So that's what's going on. The stocks determine the flows, and the flows determine the change in the stocks for the next that obtained for the next little bit. Okay, so that was one sort of modeling. That's system dynamics modeling. The next sort of modeling we'll talk about is agent-based modeling. Okay, and agent-based modeling shares the vast majority of its fundamental conceptual motivation and general need for it with dynamic modeling in general. But it has particular motivations for this subtype of modeling that are profound in certain cases. And I'll talk about that. There are certain reasons you use an agent-based model. Agent-based models are articulated at an individual level. This model here, all we did is we counted the number of people over time, for example, who were hospitalized. And this number of people changed over time. So, for example, at time 66, for a one baseline run, we had 21 people hospitalized. For the reducing the number of arriving infections, we only had 2 by that time. Mass testing of 5,000 a day led to 18 and a half on average by that time, etc. So here we're just counting the number of people. What system dynamics gives us when pursued at an aggregate level, or this compartmental modeling, which is a cognate tradition, which doesn't have a lot of the attached philosophy associated with system dynamics, and tends to be used less frequently with participatory fashion. Those give cross-sectional depictions of the state of the system over time. It's just counting the number of people here, 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 here at any one time, and then gives it to us the next day and the next day. It doesn't follow any one person throughout the system. We're not following particular individuals as they live their lives and circulate through the system. We can't keep track of an individual's history, of the number of times they were exposed or under what context they were exposed. Agent-based modeling, we can. This is a modeling approach articulated at an individual-based level. But being a system science technique, it focuses on the interaction between the pieces and the whole. The pieces may be individuals, but they are far from solitudes with one another. And they shape, ladies and gentlemen, the dynamics observed for the system as a whole. So in agent-based models, we have one or more populations that are simulated, and they're composed of individual actors, or what we call agents. Each of those agents is associated with some characteristics, and collectively it's some sort of more or less constant characteristics like their ethnicity, their birth weight, their income, if we consider that constant for the sake of it, etc. And you might consider, for the sake of a given simulation for COVID, their SES status or their housing status to be a parameter of a person, where they live, etc. In addition, we characterize their state, and then we characterize actions which can occur and rules that trigger those actions in a way for interacting with other agents. We have to specify the time horizon and the initial state. This shares tremendous amounts with like system dynamics modeling, in the sense we have a time horizon, we have a model depiction which characterizes the state of the system, we articulate how that state changes given the current state. Those things carry over as well. We have to specify for both an initial state. But the details are rather different. In system dynamics modeling and compartmental modeling, we sort of subdivide the population according to the state. We sort of put people in different boxes according to their status, whether they're susceptible, exposed, infected, recovered. In other words, we organize the model according to the characteristics of people. That's the kind of building blocks the model have to do with their characteristics. And each stock counts the number of people. The data computed is just the number of people in each stock. For agent-based modeling, by contrast, each person is represented. We organize the model not around stocks and flows, but around people. And each person keeps within it its state and its characteristics. So instead of having those be the fundamental principles of the modeling by which we organize it, we have the model organized around agents who evolve according to their state and their properties as articulated in a structured way. So this sounds very abstract. Let's imagine a case here. So we have a population, and this population might be composed of dozens, hundreds, thousands, or for our COVID modeling, commonly hundreds of thousands of agents. These individual agents have faces upon the world frequently. We can place them here. Often they have a geographic location. They circulate in some situated environment. And they have some parameters. They have some characteristics. So each might have, for example, an ethnicity, a birth sex, and an income. They might have a gender which is different than the birth sex. And in the simulation, we might have the given population, which occurs many such people. And any given person in the population will have a specific value for these parameters, a specific assumption it has about their ethnicity, sex, or income. So maybe this person here, for example, is an African American or African Canadian female with a certain income. This other individual, also African American male with a different income, etc. So we can capture heterogeneity in a very rich way, and in a way that is much less awkward than with a compartmental model, it turns out, where we essentially have to duplicate model structure to capture these things, at least conceptually, if not at a practical level, at a level of if not visually. In addition to this, to these fixed characteristics, each person has a state. Remember, the whole idea of these sorts of models, whether system dynamics or agent-based, is they have some state. They have something that's changing. These things don't change. They're more or less fixed properties. We need state. We need something that will evolve them. And where does that state live? Well, in system dynamics, it was spread amongst these different areas, these stocks. But in agent-based modeling, the state is kept within the person. So that's how we're going to do it. We're going to have a state, and within each state, we're going to have things like state charts, which will depict their evolution. And for some reason, here. So we have some state charts. So for example, we might keep track of, is this woman not pregnant, or is she pregnant? And there might be some fertility rate by which she becomes pregnant over time. And her likelihood of transitioning from the not pregnant state to the pregnant state, her likelihood of making that transition may depend on her time since the last pregnancy, etc. Her age, etc. We might have a model depicted in terms of natural history of some infection. And we have associated transitions associated, for example, with exposure, which might confer infection in some cases and otherwise leave someone susceptible. When infective, an individual might expose to others, and each individual might be classified not only with one, but multiple such state charts at a given time. So at a given time, they might be in a certain state with respect to their coronavirus infectivity. This is not a coronavirus one. With respect, another towards their attitudes with respect to seeking care, something that was tragically absent in many cases, for example, in the very troubling outbreak in New York City, because of lack of access often to care resources, because of lack of health insurance or adequate health insurance, difficulties with transportation, etc. Finally, and this is critically important for agent-based modeling, particularly with respect to cognate traditions like microsimulation, we need a means of interaction with other agents. And we do this by putting people in environments. So we often link people up in an agent-based model into networks, where a person is linked in up with one or more other people within the same population. Within these sort of contexts, we also will frequently put people within a geographic context. And indeed, within our Saskatchewan models, agent-based models for COVID, for example, we do a great deal of work adapting them to particular community settings. For example, La Loche Clearwater to help advise and provide guidance to the MHOs for outbreak control measures, or for other outbreaks in Saskatoon associated with long-term care, better understanding the long-term care context. So in these ABMs, we can situate people in particular environments, whether they be connectivity defined, like networks, geographic, or both. And recall that agent-based modeling are a type of system science technique, a type of dynamic modeling. And as such, they often exhibit emergent behavior. And within this emergent behavior, the whole is often greater than the sum of the parts. We see this in ABMs not only for patterns over time, such as we saw well illustrated through these depictions within the context of a system dynamics compartmental model, but with agent-based models, having this extra element of context, this richness of context, we can capture other things. True to the maxim and principle of critical realist philosophy of needing context, mechanism, and outcome. Here we can dignify context at a level that is not fully met within the context of aggregate models. So we can put people in space, for example, and we can examine patterns of spread within that space. Here, for example, the red indicates contamination of the area by prions deposited by chronic wasting disease infected deer. Those prions are important because not only can deer directly acquire the infection from one another through direct contact, nose to nose, as it were, but also through exposure to the environment, prions in the environment. So in this context for infectious disease, often we have some core mechanisms represented, natural history of infection, behavior, etc. And then we may have some other types of calculations like cost, quality of life, etc. that are totaled up. I think, in the interest of time, I see a number of questions have arisen here, and I am eager to try to help address some of the questions. I was thinking, if there were acclamation for it, potentially I could go and explore a little bit more of interactive model exploration, but I think my priority here would lie on answering questions, and I think I'll see if I can do so here. Okay, I'm trying to view the questions on another device, but with limited success, obviously. This is not going to be that good. Maybe what I'll ask Krisha to do is if you could read out questions for me, or we could take them live if requested from the students now, and we can use the balance of the time for this purpose.
Yes, go ahead, students. If you want to ask some questions to Dr. Osgood, now would be a good time. I think the last message was from Tyson about the 844 class. If students are in this class and they have to attend that one, then they can go ahead and attend it.
Okay.
But I don't see anything else here on the chat.
Okay, I heard beeps, so I figured those might be chat messages, but maybe there were other beeps summoning to urgent outbreak response for the SHA. Questions additionally from students then beyond what's indicated by the chat. I'm keen to use these final 15 minutes to greatest effect, and if there are any questions, I'm glad to answer them.
Looks like David has a question. David, did you want to go ahead?
Yes, I was wondering a little bit about back to your dynamic model.
Okay.
When you're applying, for instance, like an intervention.
Yeah.
Say for a given intervention, like closing restaurants or something like that.
Yep.
When you're trying to anticipate, how much that's like, how do you come to like a certain number in terms of reducing the number of interactions based on a given intervention, or
yeah.
How does that decision come about?
So this is a wonderful question. I'd like to thank David for raising it. So the question is, as I understood, is sort of how do we, if I could abuse it in my own terminology, how do we operationalize interventions here to fit it into the language I use? How do we, sort of represent them in a way we can use a model to address their needs? So what I'll observe here is that I noted that models are built for certain spheres of use. And a model such as you see here, as I had noted, I tried to give a model that would have a little bit more texture, but would avoid a lot of the detail that are in some more extensive models, even of this sort, that we build, whether it's for example, subscripting by age and chronic disease and sex, or whether it's aspects of more detailed representation of care processes, etc., asymptomatic. So much of the question, much of the way of answering this, I think properly, is to note that different models have different types of interventions for which they could be used. If the goal of the model is to examine interventions, there's certain types of interventions that will be more suitable to this sort of model versus another sort of model. Case in point, for a model such as this, we saw some interventions that we characterized, for example, associated with mass testing or shutting down, restricting arrival of asymptomatics, mixing at sort of a broad level within the population. Variants of this sort of model that I haven't shown you include, for example, some representation of contact tracing, representation that might relate to acute care related interventions related to sort of who is admitted for ICU care, who is treated at a hospital versus a long-term care facility or what have you. Those sort of things are suitable for examination in this area. And when we're dealing with an intervention type that's fairly broad brush, let's say closing schools, there is an evidence base that we might draw on as far, how we might capture that or operationalize it in terms of reduction in effective mixing. How much that reduced the number of contacts per day, for example, that the average person in the population experiences. So broad brush interventions like that can be readily handled. By contrast, when it comes to more fine-grained interventions, we will often turn to agent-based modeling. And what I'm going to do here, because it is so quick, even if it is ad lib, is just call up a recent presentation we gave in late April. This is now rather dated in terms of the scope of our models, but I figured people might find this interesting. There is a video of me delivering this online at my YouTube channel. I do have a YouTube channel with somewhere between 2,000 and 3,000 videos, much of them focused on health modeling. And one of the things I talk about here is our modeling associated with agent-based approaches. So this is a depiction of the model, and this is quite old. We've so enriched the model since then. But this is the sort of model where you could look at more detailed facility-specific closures. They would include, for example, closures associated with healthcare facilities, closing facilities to visitors for long-term care, or for a hospital. Could include closing associated with schools. But a model like this would be suitable for example, representing restaurant closures or representing the effects of a closure of a or opening of a homeless shelter, etc. And we've done exactly that sort of thing for some of our northern colleagues. So a model like this will simulate people's movement within the community in a sort of geographic context. And they would need to simulate, David, not just care seeking, but food seeking, like use of restaurants by individuals within the context of the community. And you would actually characterize within that context how many people, the risk of infection transmission. Unfortunately, there is a literature on this for restaurants, which incidentally is somewhat disturbing in terms of its ease of transmission. Now, we've done exactly that sort of thing with other resources, case in point being with long-term care or with homeless shelters. And so you'd simulate those visitations to that facility. You'd simulate that risk of transmission there, just as another facility we've done that for is dialysis facilities. And then you could say, okay, suppose you stop them going there now. How would that change the number of infections that occur within the community? And you would need to run the model many times, likely, because it is stochastic, and you would want to move beyond the flukes of a single, as we say, realization. But you could find sort of a net impact that restaurants being open across the city have on elevating infection, and by extension, when you close them, how it would lower that burden. It would require representing restaurant-seeking behavior on the part of population members and transmission at restaurants. So you would use the tool for the job, which in that case is not properly, in my view, someone who's built hundreds of models of both sorts, it's not properly an aggregate model. It would be an agent-based model such as the one that we use day to day to advise our health authority and Ministry of Health and MHOs through the province. So I hope those comments are helpful. Great question. And in general, which model you use for which question is one of the arts of modeling. And building the right model for the questions you care about is very important. Other questions?
Any other questions, guys?
So I take that as a sign of one of four implications. People are feeling wholly confident and inspired to engage in dynamic modeling, convinced that it will that it serves an important component of the EPI and public health toolbox. And if so, I'm absolutely delighted, and I encourage you on your journey. Secondly, it is possible that individuals have had to depart for the other class. Thirdly, it is possible that people are so overwhelmed that they don't know what to utter and are holding back. And fourthly, that they have uniformly and without exception, with the sole exception of David, fallen asleep. And I'm not sure which it is. Given my volume of communication, I suspect not the latter, at least.
Yeah.
Okay. Any other final questions, though, for me, in all seriousness? I heard a beep.
Oh, yeah. Lindsay Kaufman. Oh, okay.
Okay. Are there
Any more? That's it?
any questions to ask, ladies and gentlemen?
Going once, going twice.
That's right.
All right. Okay, then. So thank you very much, Dr. Osgood, for that wonderful lecture on the uses of modeling and how models work, and for providing us with an actual model to go through. So now students probably know what simulation is about, and there is an echo in the audio. Not sure why that's happening, but anywho, hope everyone learned a lot about that, and yes, let's give him a round of applause. If you can all unmute your, we can just clap through.
Thank you.
Thank you very much.
Very good. Thank you. It's an honor to be here, and I hope this conveys some useful information.
There is one more question in the chat there from Hunaria. Are you all right if people email you with questions?
Yes, I am glad to do that. Please be aware that I am working 2 jobs right now, one for the university, one for the health authority full-time. I'm seconded to the health authority through December, and I rarely get to sleep before midnight, and it's hard for me to keep up fully on my emails from both those areas, which accumulate at a dizzying pace. I'd be glad to receive that email, and maybe if the questions are textured and substantive, that I will suggest having a meeting to discuss them instead, so that the information can be conveyed more quickly. And that may require some time to arrange, just because of the schedule. We are dealing with 3 outbreaks right now, and my services are in high demand with the health authority and ministry. Thanks.
Yeah, understandable. Thank you very much, Dr. Osgood.
Thank you. It's a pleasure. Take care there. Thank you, Krisha.
Take care. Bye.
Take care.